So 2 minutes to go live. You can turn on your camera and keep your PPT ready on screen. Once we go live, sir, I'll introduce you and the topic. Then we'll be handing it over to you. And from there, you can proceed, sir.
Fine. That's perfect.
Okay. So it's sharp 5:30. So with all your due permission, can we begin?
Yes, please go ahead.
Good evening, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. Well, he needs no introduction, but it's our pleasure to introduce him at our platform. He is none other than the very renowned Dr. B.B. Rewari, sir. Sir is MD, FRCP, FICP, FIACM, FIAMS, FIMSA, FCCP, FGSI, and MPH. Sir is also the former regional advisor of hepatitis, HIV, STIs, World Health Organization. Sir is also the regional officer for Southeast Asia, clinical professor at Global Health University of Washington, USA. Sir is the adjunct professor of public health, JSPH, former associate professor of medicine, PGIMR, and RML Hospital, New Delhi. Sir is also the vice dean of Indian College of Physicians. So we have an stalwart with us at our platform today for covering the topic on current and future trends in management of a person with HIV infection. So before moving on to today's session, let us have a brief look on what the topic says. In this enlightening webinar, we will be exploring about the ever-evolving landscape of HIV infection management. In this dynamic session, we will delve into the current state of HIV care, discuss the latest advancement in treatment modalities, and glimpse into the promising future trends that holds the potential to revolutionize how we approach HIV infection. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you. Good evening, everyone. Thank you to IJCP Group and MedTalks for giving me this opportunity to reach out to you with the current and future trends in management of a person with HIV infection. And I have tailored this talk to general practitioners and try to keep it simple. And if you require more information after talk, you can always reach out to me, or I can share the references also. So we know the journey of HIV spans over last 4 decades, and the decade of 80, when this was first discovered, was decade of devastation. This was followed in 90s by a decade of discovery and actions. We discovered the virus, and then we had antiretroviral drugs. And now we are talking about ending AIDS as a public health problem by 2030. There were initial quick strides on HIV care after the first case was diagnosed in 1981. Just 2 years later, we had the virus discovered, followed by a diagnostic test in 85 and 87. First antiretroviral drug, which is called AZT or zidovudine, was approved for use in HIV infection, but this was a monotherapy at that time. 1996 basically came in what was earlier called as HART, highly active antiretroviral therapy, and is now called as active only just antiretroviral therapy. And by 2006, we had new class of drugs called protease inhibitor, which brought in basically in 1996, which brought in a revolution. And by 2006, we had newer drugs. Once daily active antiretroviral therapy became available, which was more tolerable. And now we have got number of options. But management of HIV infection broadly is a multidisciplinary approach. It requires definitely a physician or internal medicine specialist, but also needs to involve a lab expert, a nutritionist, a psychologist, and very importantly, caregiver of the person. It is very important to confirm the HIV infection first before you start on the management. And management revolves around 4 key pillars. And these pillars are basically a general management of an HIV infected person, treatment of any opportunistic infection he may be harboring, also preventing opportunistic infection through chemoprophylaxis for specific OIs and antiretroviral treatment. We also aim to prevent the transmission of HIV infection to others also. When I said confirmation of HIV infection, it is very important that we understand that this is a big shock when a person is labeled HIV positive, as it is not a curable infection. There was a lot of stigma in initial phases, though it still exists in some form. A diagnosis of HIV definitely leads to a lot of depression, suicidal tendencies, a lot of psychosocial issues. Though it was earlier thought to be a virtual death sentence, now it is considered to be a chronic manageable disease. But when I say we need to be very sure that person is HIV infected, and what I mean by this is that you have to look at the report. The report basically should mention that HIV has been tested with 3 different kits before being labeled positive. I will not go into detail into the strategy, but many private labs give HIV report with just a single test. We know that sensitivity of the HIV test is 99%, but specificity is 98%. So to rule out that 1%, 2% chance, basically, we do a sequential testing with first, second, and third kit. If first test is positive, we do with a different antigen. If the second is positive, we do a third antigen to detect antibodies. So be very sure that this has been done, testing has been done this way. So once a person has confirmed HIV infection, like any other infection, we need to take history, we need to do clinical examination, need to do certain laboratory investigation. So I'm just highlighting key points which we need to keep in mind, particularly for a HIV infected person, other than the general physical examination and history taking. Most important of these is basically a 4-symptom screen for TB, ruling out TB with fever, any history of fever, weight loss, cough, night sweats. Any of these being present, you should suspect TB. Even a 1-day cough, you should suspect for TB. Then you have to look into any other persistent symptom like a persistent headache, poor concentration, seizure. These could indicate basically some of the opportunistic infection like cryptococcal meningitis, toxoplasmosis. Then we have to look into history of diabetes, hypertension, oral contraceptive pills, because these will have implication on the treatment that we choose. We have to look into basically family history, any previous history of the treatment, any substance abuse, whether the person is using alcohol, any intravenous drugs, and what is the psychosocial history. In examination, besides the systemic examination, we need to look into white spots in the mouth, painful deglutition, to just see for any oral or esophageal candidiasis, genital ulcer to look for other STIs, some discharges, lymph node enlargement. Baseline investigation. Any person with HIV infection does not need many investigation. You have to direct investigation based on the symptoms, but certain basic investigation have to be done, which include a hemogram, urine routine microscopic, a fasting blood sugar, renal functions, liver functions, VDRL, CD4 count. If you have facility for hepatitis B and C, you must do it, and a X-ray test. All other investigations should be based on symptomatology to rule out any opportunistic infection, and we should not subject a person to long list of investigations. So this is just to tell you the principle of antiretroviral therapy. These antiretroviral drugs of different groups, they act on the different steps in the replication. This is a HIV virus which is entering a CD4 cell. This is a CD4 cell. And once it sheds its RNA, which is converted into DNA by enzyme called reverse transcriptase, which is then integrated into the nucleus of the host cell by enzyme called integrase, and then there is a transcription, and then budding out of the virus which are found in millions of numbers and bud out by enzyme called protease inhibitor, protease enzyme. So all antiretroviral drugs act at different stages in the replication, and they are named by the site of action. Drugs which act at reverse transcriptase enzyme, inhibiting them are called reverse transcriptase inhibitors. Drugs which inhibit integrase enzyme are called integrase inhibitors. Similarly, drugs which basically prevent the cleavage of messenger RNA, they're called protease inhibitors. So accordingly, these drugs have been classified in different groups. I'm not going to read into the full details, but these are different groups of the drug that are available. So what are our goals of antiretroviral therapy? We know that currently available drugs cannot eradicate virus from the body. They can only stop the replication of the virus. So our aim is basically that we stop the replication of the virus to the greatest possible level so that virus cannot destroy the CD4 cells, and CD4 cells starts regenerating, and there is immune reconstitution. And if the immune reconstitution happens, then the opportunistic infections go down and there is improvement in the quality of life. So our aim is to suppress virus, but we should sequence our drugs in a way that we maintain future options also when we are using certain drugs in the first line. And by reducing the virus in the blood, we are also able to actually prevent the transmission of virus from the infected person. When do we start? This has been a question for many years, but over the years, the cutoff value of CD4 for starting ART has been changing. And since 2016, the evidence from various randomized clinical trials showed that you can start antiretroviral therapy, or you must start antiretroviral therapy for everyone who is infected with HIV, irrespective of the CD4 count, irrespective of the clinical stage, irrespective of the viral load, because the benefits that were seen from the START trial and the trials basically over the years show that starting ART early has got independent benefits in terms of reduction in viral load, immune reconstitution, and also reduction in the deaths. So since 2016, guideline has been to start antiretroviral therapy in all HIV infected persons, regardless of CD4 count or clinical stage. Because with early ART, the response is more robust. There is a reduction in mortality. The T cell activation and inflammation is reduced. So there is a reduction in the HIV-related morbidity independent of CD4 cells, like conditions like HIV-associated nephropathy or HIV, cardiovascular diseases, neurocognitive complications. So early ART has got significant benefits in terms of T cell activation, reducing T cell activation and providing these benefits. Over the years, basically, the guidelines have evolved, and the current norm is that we have to use 3 drugs, and these have to be from 2 different groups. That is the norm. The question may be that why we cannot still cure HIV when we can stop the replication of virus. The answer to this is that despite viral reduction to undetectable levels over the period, there is still evidence that virus may be still replicating in certain parts of the body, which includes basically macrophages, T cells, in brain, lymphoid tissue, spleen, and other areas. The virus may still be present, and as soon as you stop the antiretroviral therapy, this will start replicating again. So antiretroviral therapy is a lifelong therapy. We use 3 drugs. We use drugs from 2 different groups, and the current standard is to use 2 NRTIs, that is nucleoside reverse transcriptase inhibitors. We use tenofovir 300 milligram, lamivudine 300 milligram, with 1 integrase inhibitor, that is dolutegravir 50 milligram. And these 3 drugs are basically preferably used in a single tablet, that is fixed dose combination of 3 drugs. And this is to be given at any fixed time, once a day, for lifelong. Now, question is basically till 2019, we were using combination of tenofovir, lamivudine, efavirenz, but now the standard of care is used dolutegravir, because this evidence came from number of studies single study, flamingo study, spring study, sailing study, in which almost 3,000 patients basically were randomized to two different groups using dolutegravir, abacavir 3-TC, and using tenofovir, FTC, and efavirenz. And these studies shows that viral suppression with the dolutegravir-based regimen is rapid. It happens within 4 weeks compared to 12 weeks with the efavirenz. It has got fewer toxicities, minimal discontinuation of treatment due to side effect, 2% with dolutegravir versus 13% with efavirenz. It's a more potent regimen. Over 96 weeks of the study period in these studies, there was no known treatment emergence resistance because it has got a high genetic barrier and it has got very minimal drug-drug interaction. Very important, it is effective against HIV too. You may be knowing that HIV basically is HIV 1 and 2, and 97 to 98% of people have HIV 1. 2 to 3% of people have HIV 2, and some people have got HIV 1 and 2 mixed infection. Efavirenz-based therapy was not effective against HIV 2, but dolutegravir-based therapy is effective against HIV 2. So with all these things, it makes dolutegravir a very ideal choice. So in 2019, WHO updated the guidelines that our preferred first-line regimen will be tenofovir with lamivudine, 3-TC's lamivudine, and dolutegravir. Those people who cannot use dolutegravir for some reason, alternative regimen will be tenofovir, lamivudine, and efavirenz in the dose of 400 milligram rather than 600 milligram, which is being used presently. Similarly, dolutegravir was basically brought in the second-line regimen also for patients who are failing on efavirenz-based therapy. They will be switched to a second-line regimen containing dolutegravir. Such a wonderful drug, but still there are some side effects seen in 1 to 2% of the people, but very minimal side effect. If you see, the side effects are lack of sleep, headache, dizziness, tiredness, which settles over a period of 2 to 3 weeks after starting treatment. The other side effect is basically a DTG-associated weight gain. I'll show you that there is a weight gain of 3 to 5 kg with the current regimen that you are using, and this evidence comes from various studies. So it is very important that these are the studies, advanced study, NAMCEL study, and SIPAMO study, which showed that there would be a weight gain. Initially, weight gain was taken to be a favorable outcome because the people living with HIV generally have a low body weight, but weight gain was taken as a favorable outcome. But over the time, a significant weight gain basically can lead to additional problems like cardiovascular disease and other hypertension and diabetes. So it is very important that when a person is provided dolutegravir-based regimen, importance of healthy diet, avoidance of tobacco, regular exercise is highlighted to the people in terms of managing weight. When dolutegravir came in, basically there was some concern about neural tube defects, basically, because in 4 out of the 426 women who were taking dolutegravir and became pregnant, they had neural tube defects. But over the years, it has been seen that this has reduced significantly from 0.94% to 0.3%. What I want to emphasize is that neural tube closes by 28 weeks of gestation. So if a woman is coming to you with pregnancy, it means neural tube defect, neural tube has already closed, so you can safely prescribe dolutegravir. But if a woman is already on dolutegravir and becomes pregnant or wants to become pregnant, you have to counsel her that there is a minimal chance, very minimal chance of having a neural tube defect if you're on dolutegravir and become pregnant. But the benefit of dolutegravir significantly outweigh this small risk. So you have to counsel the person on using dolutegravir-based regimen, even in women of childbearing age. But the choice ultimately has to be given to the woman. A word of caution on drug-drug interaction. Basically, there are three significant drug-drug interactions with dolutegravir. If we are using rifampicin, if the person is co-infected with TB and we are using a ATT containing rifampicin, we have to use dolutegravir in twice daily dosage because rifampicin is a cytochrome P450 inhibitor and it reduces the availability of dolutegravir. So dolutegravir has to be given twice daily. It means you have to give tenofovir, lamivudine, dolutegravir 1 tablet at a fixed time, and 12 hours later you have to give additional tablet of dolutegravir. Second drug-drug interaction is with metformin, because many of the PLHIV will have diabetes also. we may be on metformin. Basically, metformin dose has to be reduced because the dolutegravir, the dose has to be fixed to 1 gram per day, while we know that without dolutegravir, the maximum dose of metformin is 2 grams. Then very important thing which people take on their own. Many people take on their own antacids. They take, PPI inhibitors. Many of them take them for acidity. They take multivitamins which contain aluminum, calcium, iron, magnesium, zinc. So all these have got basically drug-drug interaction with DTG. So these should be taken 2 hours before or 6 hours after taking DTG. So a very simple drug, easy to prescribe, single pill in most of the cases, minimal side effect, but you have to remember that 3 drug-drug interactions important you have to remember and counsel the patient accordingly. For needle stick injuries to any healthcare workers or for unsafe sexual exposure following a sexual assault, the post-exposure prophylaxis can be given, and the drug of choice for post-exposure prophylaxis is also tenofovir, lamivudine, dolutegravir. I would like to inform you here that National AIDS Control Organization, which is running around 640 ART centers and has got almost 15 lakh people on free antiretroviral therapy, provides all these drugs, antiretroviral drugs, free of cost to the patient at these centers. Moving a little bit, we know that CD4 count is not required for ART initiation. I said earlier in the talk that we can start ART irrespective of CD4 count, but we still need to do a CD4 count at baseline because many patients, when I say many, almost 33% of the patient start when there's ART when their CD4 count is less than 200. And this is a condition called advanced HIV disease. Any person, adult or adolescent or children older than 5 years, they are said to have advanced HIV disease if they've got CD4 count cell of less than 200 cells or they have a WHO stage 3 or 4 even. Why it is important to classify patient into advanced disease? Because these people require additional package of care. Persons with advanced HIV disease have got significantly higher chance of dying. 50% of deaths which happen of people on ART are among people with advanced disease. So it is very important that they get a package of care for advanced disease, which includes screen them for opportunistic infection, screen them for TB using urine LAMP test, screen them for cryptococcal meningitis using cryptococcal antigen lateral flow assay, give them preventive therapy for TB preventive therapy, give them fluconazole to prevent development of cryptococcal meningitis if they are positive for CRAG. Start ART as soon as possible, what is called as rapid ART initiation, and give tailored counsel to people with advanced disease because they require more counseling, more follow-up than the person with higher CD4 count. So as I said, we must do a sputum test for them as first line using a CBNAT, that is cartridge-based nucleic acid amplification test, urine lateral flow LAMP test for TB diagnosis, particularly when the CD4 count is low, cryptococcal antigen screening, provide them prophylaxis with cotrimoxazole, TB preventive therapy, and also fluconazole preemptive therapy for CRAG antigen positive patient without evidence of meningitis. All persons with advanced disease should be initiated on ART within 7 days, which is called as rapid ART initiation. And those who are prepared adequately, they should be offered ART even on the same day. But I'll take a break here to emphasize that we must ensure that the person is ready to take ART. It is easy to prescribe. It is difficult to take a therapy, which is a lifelong therapy, which has to be taken every day. And you know the adherence is important. And if you're not able to adhere to the therapy, the benefit of the therapy will be lost. So patient has to understand and has to be fully understanding and has to be ready for taking antiretroviral therapy. It must be an informed decision to the patient that this is a lifelong therapy. You have to continue it with 100% adherence. You cannot stop this therapy. And these drug-drug interactions must be explained to the patient. And once the person is ready to start, only then therapy should be started. This may require 1 to 3 sessions of counseling, depending on the patient's understanding. And once the patient is prepared, only then we should provide antiretroviral therapy. Having given what is the current status of antiretroviral therapy, I would just like to go a little bit into what is the future trend. We know that when it is a lifelong therapy, person starts feeling better with therapy, he has no opportunistic infection, they tend to forget. There is an entity called pill fatigue. We know that even as healthcare provider, sometimes we are not able to do a complete course of 5 days of metronidazole or an antibiotic. So basically, we need to look into long-acting antiretroviral therapy. So these are some of the new directions in antiretroviral therapy. What is on the horizon? There are different studies. You need not remember these studies, but there are studies which are coming in, like studies like Gemini 1, Gemini 2 studies, which says even dolutegravir 3TC maybe is non-inferior to 3-drug regimen. And there is evidence on long-term durability of 2-drug regimen also, but this is not in the guidelines presently as of now. Tango study provided evidence that at week 96, when we have stabilized the patient on DTG, TDF, 3TC, we can switch to TDF, DTG, 3TC, which will be non-inferior to 3-drug regimen. What is very promising is basically a result from Atlas 2M studies, which shows that week 88 and week 96, injection of cabotegravir and elpavir, which are long-acting drugs, which can be given initially 4 weeks for 2 months, once in 4 weeks for 2 months, and then every 8 weeks. So this will simplify the antiretroviral therapy significantly, but cabotegravir and elpavir cannot be given to certain group of people. It cannot be given to children. It cannot be given to people taking antitubercular treatment and other areas. So these are some of the options that after starting a 3-drug regimen, we can shift to 2-drug regimen, or there could be a monthly or bi-monthly injection. But these are all still not into the guidelines. So we have to wait for more evidence on these. Just these are some of the single drugs which are long-acting drugs which are which are in the various phases of trials. Broadly neutralizing antibody like other conditions are also being looked into as a kind of long-acting antiviral for HIV infection. We know that Timothy Brown was a patient in Germany who has been cured of HIV by bone marrow transplantation. 6 more patients have been cured so far. But these are all patients who have got a bone marrow transplantation. They got bone marrow transplantation for a population called Caucasian population, which has got a beta 32 deletion in their chromosome, and they are resistant to getting HIV infection. So basically, these are all experimental therapies, and these are some of the future trends which are in different stages of. A little bit update on vaccines. There are different vaccines, basically trials undergoing, and these include phase 2B and 3 vaccine efficacy trials. But this study was stopped because there were more infections in the vaccine group versus the placebo group. Similarly, in HVTN 705, again, 51 of the participants in active vaccine arm acquired HIV versus 33 in the placebo group. So efficacy was just considered to be 25%. So study is not being continued. So just to summarize my talk, the current trend are towards earlier initiation at any CD4 count, simpler treatment with a preferred regimen of tenofovir, lamivudine, dolutegravir in one single pill once a day. These are less toxic, more robust regimen. Better monitoring through a viral load test done at 6 months after initiation of ART, and then if person is stabilized, viral load is suppressed, undetectable, you do viral load test once in a year. So the carry-home message is antiretroviral therapy is a lifelong therapy. CD4 is not required to start ART, but it is needed to diagnose people with advanced disease. Treat all concept means all persons diagnosed with HIV are eligible for ART initiation. Counseling of the person and one caregiver at least is important for preparedness. Healthy living practices must be emphasized before starting ART. And monitor patients on ART by viral load at 6 months after ART initiation, and then annually if virologically suppressed. So that was in brief the current and future trends in the HIV infection management. This is my email, my name, bbirivari@hotmail.com, and my mobile number. You can reach out to me anytime. through either email or through WhatsApp at this number. Thank you very much.
Thank you so much, sir. Thank you for sharing such wonderful insights upon such an important topic that we have covered today. Thank you to all the viewers as well for staying tuned with us and for hearing us out throughout the session. Well, we have received few questions, sir. With all your due permission, I would like to put across those questions to you.
Sure. Please.
Yeah. So the first question is from Dr. Gaurav, and Dr. Gaurav wants to know, is AIDS any way different from HIV?
Okay, so that's a good question. You know, HIV stands for Human Immunodeficiency Virus. It is the name of the virus. AIDS is Acquired Immunodeficiency Syndrome. So when HIV virus enters one's body, it starts destroying its immune cells, which is called CD4 cell. And when these cells are destroyed, person starts getting different infection. So group of that infection is called as Acquired Immunodeficiency Syndrome. So HIV is a virus. The disease caused by it is HIV infection. And when HIV infection happens, number of opportunistic infections happen due to loss of immunity, and that condition is called as Acquired Immunodeficiency Syndrome.
We are receiving a part question to this from Dr. Gaurav. Dr. Gaurav wants to know what needs more attention, HIV or AIDS?
As I have explained, we need to prevent people from getting infected. So we need to give very clear messages how HIV spreads and how HIV does not spread. So if HIV infection is prevented, you will not get AIDS. But if a person has got infected with HIV, we need to basically start him on antiretroviral therapy so that he doesn't progress to the stage of AIDS. And if we can start treatment early, his response to therapy will be more. So HIV can be prevented, but if HIV infection has occurred, then you need to provide the treatment, what is called antiretroviral therapy.
Thank you so much, sir, for answering this question. We will take up the next question that we have received, and this question is by Dr. Sarita. Dr. Sarita wants to know, is HIV infection a universally fatal diagnosis?
Please repeat the question.
The question is HIV infection a universally fatal diagnosis? Yeah,
HIV infection is a term which has been used globally across the globe. And these are terms which are HIV and AIDS are the terms which are actually used across the globe.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the question is, how do CD8 plus T cells combat HIV?
You know, CD4, basically, HIV infects the CD4 cells and kills the CD4 cells. So it alters the CD4-CD8 ratio. And initially it was thought that CD8 cells provide protection, but now we no longer do a CD4-CD8 count. Earlier we used to do CD4-CD8 count. And these days we only use CD4 counts as a marker of the degree of the immune suppression, that how much of the CD4 cell. You know, normal person contains anything from 800 to 1300 CD4 cells. And over the period, once person gets HIV infected, HIV starts destroying CD4 cells, and there is a decline of 50 to 60 to 100 cells every year. And over 5 to 6 years, your CD4 count may come down significantly if treatment is not provided.
Thank you so much, sir, for answering this question. We will take up the next question that we are receiving from Dr. Kuldeep. Dr. Kuldeep wants to know, is the body's innate immune response as important as the adaptive immune response in case of HIV?
Yes, both responses are important, but innate immune response is basically also important because your level of immune suppression and your response to antiretroviral therapy will depend on that. And it is important that the CD4 cell rise, which happens after the treatment with ART, is both qualitative and quantitative. So when we say qualitative, it is the innate response, which is basically responsible for good quality CD4 increase, not only increase in the number.
Thank you so much, sir. Thank you for answering this question. We will take up the last question from Dr. Simran, Dr. Simran wants to know, when should antiretroviral therapy can be given?
No, as I said earlier, antiretroviral therapy should be provided to all HIV infected person, regardless of their viral load, regardless of their CD4 count, regardless of clinical stage. Because we have evidence from number of trials, randomized control trial, which basically divided people into different groups. Those where ART was provided at CD4 below 500 and those where ART was provided above CD 500. These were START trials and temporal trials, and benefit were seen even starting ART, even at a higher CD4 count, helped in reduction in the new TB activation and also in the better response. So treatment should be provided as soon as HIV infection is confirmed.
Thank you so much, sir. Thank you for answering all the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers for their ardent participation that they have shown by being with us throughout the session and putting across their questions to us. So thank you to all of them. And with this, I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights with all our viewers who are present here and for solving their queries. We really hope that this particular insight of yours will definitely help them in their daily clinical practices. So thank you so much, sir. Thank you for that. So with all your last comments, sir, we can conclude the session here for today.
Thank you. Thank you. Thank you, everyone.
Thank you so much, sir. With this, we are concluding the